Thank you, everyone, for your interest in this topic. My name is Ayman Tarabishi. I'm a fellowship trained interventional pain specialist with the special interest in advanced neuromodulation and spine endoscopy. The learning objectives of this topic are to talk about advances in treatment of chronic foot and ankle pain conditions, especially when it comes to neuromodulation, to distinguish new waveforms of spinal cord stimulation, what's real, what's a gimmick, and then to talk about the true advance of neuromodulation, which is dorsal root ganglion stimulation. And finally, we will touch on the role of peripheral nerve interventions in the management of chronic foot and ankle pain conditions. So, when looking at any foot and ankle pain condition, we can classify it into acute, expected, predicted, justifiable pain, like post-trauma, post-surgical pain, acute radiculopathy, sciatica, which is a pain that's treated by treating the underlying condition. Then you have a group of patients that won't progress the way you anticipate them to after surgery, and they continue to have some subacute, post-surgical, or hardware-related pain, or some early cases of entrapment neuropathies or joint and tendon pathologies. Then you have your subgroup of patients with the types of pains that we simply cannot cure, the pain that will not resolve or go away. Chronic pain conditions like CRPS, neuropathies, deformities, spasticity, post amputee phantom pain, and so on and so forth. So, you're going to approach your patient with a combination of modalities, therapies like physical, psychologic therapies, bracing, inserts, medications, Tylenol, NSAIDs, nerve pain medications like SNRIs, gabapentinoids, the gabapentin, Lyrica type of stuff, topicals like lidocaine, capsaicin, or even opiates in some cases if the benefits outweigh the risks and if they're justifiable, obviously with a lot of care in those cases. Then, when it comes to interventions, whether it's performing a nerve block, a joint injection, tendon bursa injection, or performing an operation, reoperating, revising a surgery, removing hardware. And each of your patients will have a combination of the above modalities based on their pathologies, needs, medical comorbidities, and sometimes unfortunately limited by what their insurance covers and permits, regardless of what their ideal treatment plan may be. So there's no one right formula that works for everybody. It's tailored to each of your patients, based on their clinical picture, based on their medical comorbidities, what's indicated, what's contraindicated, and even taking into consideration their work and functional status, if there's a secondary gain like a workers' comp auto injury case, and things of that sort. So, is there anything we can do to address or predict which of the patients will be, for lack of a better word, the troublemakers, or the patients who are going to end up in a chronic post-operative pain and end up with chronic complaints and not get better and not go back to work and ask for pain pills and kind of these dreaded chronic complaints? Is there anything we can do about it preemptively or prophylactically to limit and curb some of these issues? So some of it we can look into factors related to the patient. So we all have some of these patients that, sorry to put it this way, that are you could call them a little crazy. So patients that have history of substance dependence, psychiatric diseases like depression, anxiety, insomnia, physical, psychological, sexual abuse victims, history of other functional pain conditions, your fibromyalgia, irritable bowel syndrome, interstitial cystitis, insane list of allergies. Those patients are obviously much more likely to have chronic post-operative pain and have poor surgical outcomes. Then you have factors related to the surgery itself, like someone with a mangled extremity, a polytrauma, lots of hardware, X-fix, pylon fractures, calcaneus involvement. You're doing, a big Charcot or cavus deformity reconstruction. Patients who are poor healers, like your diabetic smokers, peripheral vascular disease. And sometimes it's just luck. It's unlucky. You don't see any of these factors, and the patient ends up being a chronic pain patient, develops CRPS, develops some other unpredictable chronic pain condition. And in that case, there's nothing that could have been done. But let's say it's one of the cases that something could have been done. So if it's something patient related, so how to address some of these factors and limit some of the chronic post-op pain in these patients? So let's say if the surgery was elective, then we can look at prehabbing the patient. This is actually a common concept in back surgery because a lot of chronic back pain patients end up categorized with crazies, and a lot of them unfortunately end up on high dose opiates and uh, end up with a lot of other psychological issues. So there are some academic programs that won't perform back surgery on a patient until the prehab team signs off of them. And a lot of this is psychological and social treatments um, uh, with things like optimizing their social support, their psychotherapy, some weight loss things, some of them stop smoking, treating their pain amplifiers that make them feel pain more so than it really is perceived, in treating their anxiety, stress, and insomnia, and some of the medications that help with nerve pain and optimizing all of that. And only then they would proceed with elective surgeries. Then, if the surgery was emergent, trauma, something of that sort, there's not a ton that can be done, but you can involve psychological support sooner than later. Um, there are some studies that show that certain supplements like high dose vitamin C, 500 milligrams twice a day, lowers the risk of developing complex regional pain syndrome and extremities surgery. Magnesium oxide does show some help as well. So these are harmless supplements. There's no harm in adding them. And always involve physical therapy early and aggressively. Early mobility, range of motion, ambulation if they're allowed to bear weight. Just don't allow them to lay in bed and catastrophize, lick their wounds, and magnify their victim mentality. Have them focus on function and progress, and take their mind off the pain and the wound and that sort of stuff. Then factors that are surgery related. So if you know that the surgery is going to be extensive and painful, there are many things that can be done as an preemptive anesthesia and analgesia, using nerve blocks, long-acting nerve blocks like with the liposomal bupivacaine Exparel, um, using a lot of local anesthetic in the area, using a mixture of a short and long-acting local anesthetics like lidocaine, bupivacaine with epi, so it stays longer in the tissues and gives them more post-operative pain relief. And schedule their non-narcotic pain medications post-operatively. So if you want to put them on a scheduled regimen of a gabapentin, magnesium oxide, a muscle relaxant, and Tylenol. Some surgeons have an issue with scheduled Tylenol that could mask a fever. So if there's an infection, and Tylenol masking the fever, that could be an issue. But if you're okay with that, that can be helpful for pain control. And in severe cases, consider a PCA. Um, and of course, if you're giving them PRN narcotics, treat their side effects, give them something PRN for constipation, nausea, and those other side effects. So I'll touch briefly on a PCA because I feel that it's greatly misunderstood. Because with the PCA, the patient will be getting less pain medications than IV pushes in total, and in many cases, and will be getting better pain relief because they'll remain in the therapeutic window. They won't have the peaks and valleys. They'll have small dosages, more frequent small dosages that can be achieved by having that a nurse is not going to be available to go give them a IV push of a tiny dosage every 12 minutes, every whatever interval you put. But by allowing that on a PCA, you keep them in a analgesic concentration window, which keeps them in that, and they don't get the euphoria from an IV push. So say you put someone, just to give you like a quick example, give someone in a little morphine PCA or whatever, dilaudid PCA, put them on a 0.1 every 15 minutes, and the patient uses it to the maximum amount that they're allowed. That's 1.6 milligrams in 4 hours. That's better than giving them 2 milligrams Q4 PRN pushed by a nurse. That's 20% less dosage. It's much less work for the nurse. The patient always complains that the nurse wasn't there on time when they asked for their pain medicine, and they were in pain. And at the end, they got better pain relief with less analgesia, or with less pain medications. And again, they don't get the euphoria because they're getting micro dosages. And it's unlikely, so that it's kind of one of the protective mechanisms of it is that if the patient gets more of a dose, they get too groggy, it makes you too groggy to operate the PCA before you become groggy enough to stop breathing. So it's almost impossible to OD in a PCA unless someone else pushes the PCA for you. And obviously don't put a basal rate. That's one of the things. Just as long as it's just a PRN, nobody's going to overdose in a PCA. Not going to go over these too much. So disadvantages, obviously, the patient must have the mental capacity to be able to operate it, must have the extremities to be able to operate it. So if someone is a polytrauma with their hands in a cast, or someone who's obtunded or demented, they're not going to be able to use it. And the main thing is make sure there's no surrogate pushers. There's no family members who are pushing it for them, because that's the main safety mechanism within the PCA, that you get too groggy to push it before you get too groggy to breathe. But if someone is pushing it for you, they may push you over the edge. Now we move on to the real meat of the talk, spinal cord stimulation. So I'm going to discuss history of spinal cord stimulation, some basic anatomy, some theories of mechanism of action, advancement in software and hardware, and future of neuromodulation. So spinal cord stimulation was first introduced by Norman Shealy, which is a neurosurgeon at Duke. He's actually the guy who invented the TENS unit and radiofrequency ablation too. Pioneer in intervention pain. So initially it was for terminal cancer patients. It wasn't portable. It was hooked to a power source outside of the patient. And the leads were intrathecal and they required surgical laminotomies. So for a while, spinal cord stimulation fell out of favor until technology picked up, and smaller percutaneous epidural leads were developed, and implantable programmable batteries that are long lasting were developed. So in the 90s, we had reemergence of this therapy as a feasible solution to control patients' pain. To understand spinal cord stimulation, I'll briefly touch on some neuroanatomy. So, in the sensory signal processing pathway, we have three afferent nerves taking the signal from the periphery to the brain and an afferent nerve pathway. This is a simple picture so you can find that. So the first order neuron, the cell body of this neuron is in the dorsal horn of the spinal cord. And it has many types. Pain is transmitted mainly by two types, by type A delta, which carries sharp localized pain, which is a large thinly myelinated fibers, and type C fibers, which is non-myelinated and carries diffuse nagging pain. There's a very important reason that I'm concentrating on this, because it's one of the mechanisms of action of the spinal cord stimulator. The second order neuron is in the second lamina of the spinal cord, and it travels to the thalamus of the brain. And the third order neuron extends from the thalamus to the cortex. It allows the feeling of pain and integration of past experiences and emotions, and determines the reaction to the painful stimuli. Then you have your descending neurons. So think of them as brakes that slow down the signal from the afferents that bringing pain signals from the periphery to the brain. So some of the theories and the hypotheses behind the mechanism of action of the spinal cord stimulator are a gate theory, neurotransmission, sympathetic activity, central biasing, and endogenous opiates. So gate theory of pain, the Wallin-Melzak gate theory of pain, that says that stimulating large myelinated non-nociceptive fibers can inhibit perception of activity in small nociceptive fibers. That's where your large type A alpha and beta fibers can block the perception and from the smaller fibers, the C in that type A delta. So, sort of like if you bump your elbow and you rub it, the rubbing sensation overwhelms the sharp pain and thus makes the pain less perceptible. And so stimulating those large myelinated non-nociceptive fibers with a spinal cord stimulator sort of blocks some of the pain signals coming from the other fibers. Some of the other theories, without going into too much details about them, is neurotransmitter modulation, where a stimulator can increase the GABA release from multiple areas of the spinal cord, just decreasing allodynia. So basically, you give your patient gabapentin or Lyrica when they have pain and nerve pain for the same reason. And that's why there's some like animal research studies that trying to control pain by transplanting GABA secreting stem cells into the patient's dorsal ganglions. So GABA and the dorsal ganglia play a big role in processing pain. I mean, GABA is one of the most abundant receptors in the CNS, and it's mostly an inhibition receptor. Then you have the decreasing sympathetic activity mechanism. So that's why spinal stimulation, especially dorsal ganglion stimulation, can improve circulation for patients with peripheral vascular disease. And in Europe, spinal stimulation is used to treat angina even without chronic pain conditions and CRPS and the indications that we have here. And the US insurances will not pay for spinal cord stimulator for someone for pure peripheral vascular disease without nerve pain. Central biasing theory, that it increases the activity of the descending inhibitory neurons. As I said, the brakes that stop some of the pain signals from traveling upward. And the endogenous opiate release, it's a poorly understood theory, but it basically increases the endogenous release of endorphins and enkephalins of the body. So without going into too much details about these are some of the mechanisms. Phases of treatment of spinal cord stimulator. So the clinical process to transition the patient from evaluating a patient to implanting them start with patient selection, finding the right patient with the right pathology, and a risk versus benefit assessment. Then the patient gets to try it. The trial is usually a 5 to 7 day temporary stimulator. And if they achieve more than 50% pain relief, improvement in function, decrease in usage of pain medications, then we can consider it a successful trial and proceed from trial phase to an implant. This table shows from numerous studies of spinal stimulation coverage of certain areas with corresponding spinal levels. So notice that the foot has a dark black around T12 to L1. Thus, we can get very good coverage and response with spinal stimulation to foot and ankle pain conditions. Meanwhile, if you look at the lower back, it's kind of a light gray. There's no like dark black for the lower back. There's no sweet spot for the low back pain. And most of the patients we treat are low back pain. And most of the failures of spinal cord stimulation are for low back pain, and the explants and the bad rep is because we don't have a great solution for low back pain. But actually for foot and ankle, we can treat a lot of patients with neuromodulation if the patient is selected correctly and matched with the right therapy. So this is a table that shows some studies following patients anywhere between a year to 7 years, showing an average of more than 50% pain relief. These are studies from the 90s. These are the old systems that were much less developed than the new systems. The numbers are even better now. And even with those studies, there were studies that showed about 78%, almost 80% relief. Here is another table that shows the average reduction of narcotic pain medication usage in patients after implantation of spinal cord stimulators. So it's ranging from 59 to 90% in clinical studies. And again, those are numbers from studies in the 90s. And for those are the older generation of stimulators that have more limited capabilities. So hopefully the numbers are better now. Complications rate, in general, it is rare. The complications are rare. The highest rate is migration. Not sure if it's 24%, that sounds too high. But even though this is asterisk, so most of these, the vast majority of these migration are minor, about few millimeters, and have no clinical significance. That means they don't affect coverage and effectiveness of the device. So the device will still cover the area of the spinal cord that is needed to cover for pain. But all it needs is a simple reprogramming to where those few millimeter of migration meant that no different electrodes are the ones that have to be turned on and off and in a different setup of programming. So historically, the focus was on hardware because, again, there was a lot of need to improve the hardware. So they work on adding more contacts on the leads to be able to stimulate larger areas of the spine, have different programming capabilities, making them MRI compatible, obviously. Smaller battery sources, and patient controllers with now a lot of them are apps on the smartphone. Battery lives for chargeable versus non-rechargeable. Until there was a paradigm shift with it, until 2015, stimulators were only stimulating it as simple tonic stimulation. In 2015, a company called Nevro came with something called a high frequency stimulation, and we started seeing advancement in now wave forms and in software, not just in hardware, which opened up a lot of opportunities and options and treatments and for the patients. So I'll just show you a timeline from 1967 with Sheely. And then you have the era of first generational hardware advances from 1985 to 2015, and from 2015 to 2020, and ongoing, obviously, when we had a combination of software and some hardware advances. So the Senza trial, which is the trial that for the first advancement in software, is the study for high frequency stimulation. So prior to that high frequency, the highest frequency the stimulators used to go to was 200 kilohertz and never went up to 10,000, from 200 all the way to 10,000. Published in the Journal of Neurosurgery. And basically it showed greater relief than traditional spinal cord stimulation. So the study was more for back pain and radiculopathy, but now they have studies for other sources of pain. So for both back and leg pain, it showed a greater pain relief than traditional spinal cord stimulators. The other advantage the therapy showed that is paresthesia free. So the old stimulators, the patient used to feel kind of a tingling sensation, or not a tingling, a paresthesia basically, or rubbing sensation that was overcoming their pain sensation. But a lot of the newer programs of stimulation are paresthesia independent and paresthesia free. And this helped the patients that did not like the paresthesia with their stimulators. Also, the percentage of, they call them super responders, the patients who end up with a pain score below like a 2.5, was higher in the population that received high frequency stimulation versus regular spinal cord stimulation. And it's also showed from studies that were done in Europe that the data were replicable. So recently, they had a study of high frequency stimulation for painful diabetic neuropathy, which is relevant for in the podiatry world. So they chose patients with refractory conservative management who continue to have pain scores above 5, and followed them at 3 months and at 12 months. And testing pain scores, neurologic functions, diabetic foot exams, monofilament, and pinprick testing. So enrolled slightly more than 100 patients in each study arm with high-frequency spinal cord stimulation versus conventional care. So 3 months data was published. Even the 12-month data was published. It's not much different from the 3 months data, but the 12 months data was just presented last weekend, so it's not available to me to add to this presentation yet. So obviously you see 86% versus 5%, looking at the responder, meaning that they had more than 50% pain relief. And the conventional medical care, if you look into details, patients were on oral medications, topical medications, therapy, shoe insert, TENS unit, supplements, whatnot, stuff like that. But high frequency stimulation showed great promise in treating painful diabetic peripheral neuropathy. That added development in Nevro started more development in many other areas of spinal cord stimulation. So it was the catalyst for advancement in waveforms and spinal cord stimulation. So at that point, it was St. Jude. Now it's uh, absorbed by Abbott. Introduced what's called a burst waveforms. So many neurons in the central nervous system, they fire in burst fashion. So they actually throw a burst of action potentials, then rest and become dormant for a period. And these action potentials are fired in a decremental amplitude and have a very specific rhythm to them. So it's not a simple on-off situation. So those neuronal pathways that conduct in bursts, uh, shown in a lot of neuroanatomy studies and functional MRIs, to have stronger signal and impact in the central nervous system. So when they started to stimulate those nerves with burst stimulation, they developed the kind of signal to stimulate those neurons. So there's two unique things about this type of therapy. First of all, it has a carryover effect from the burst charges. So it's the only therapy that works when the stimulator is actually off and it's not firing. So the stimulator fires a burst and then it's off in the dormant stage, but it's the pathways are still stimulated and affected by it. Second, it affects the medial and lateral pathways. So not only it affects pain, but also affects the emotional reaction to pain and the perception of pain, which is great if dealing with patients with chronic pain conditions, because a lot of times the perception and emotional reaction to pain is worse than the pain itself for these patients. So they've had lots of functional MRIs that showed effects on the cortical pain centers in response to pain emotional processing and perception. So which you can see up top with you don't see that activation in those centers with simple tonic old school spinal cord stimulators. And obviously, there are many clinical trials showing the superior effectiveness of burst stimulation to regular spinal cord stimulation. So then Boston Scientific joined the ranks of software waveform development and came up with their WaveWriter program that allows the stimulator to perform two types of waves at the same time at two different parts of the wire of the lead. So it can stimulate the sweet spot or spinal segment for each signal type with that signal type. So thus it can stimulate the dorsal column and dorsal horns. And so because Boston Scientific, they have a patent on the longer lead. They have a 16 contact lead versus 8 contact lead. This is twice the length of the other companies. They can cover a larger area of the spinal cord and be able to easily run two different programs at the same time. So some of the other advances of software and waveforms, as I said, Nevro, they have the 10,000 kilohertz and they're coming with the 20,000 soon. Abbott has Burst. Medtronic, they have high density stimulation that in theory works more on the glial cells. Medica has dynamic and inferential. That hasn't really hit the market much. Boston, as I said, they have the Wave Rider. Nuvectra, they worked on the pulse width, not on the frequency, but Nuvectra is out of business now. That did not work out. So if you have, so that's what I said. Some people are just creating a waveform that's a gimmick, but if it's not something that has value, you're gonna go out of business like Nuvectra did. So the funny thing is, because we live in a capitalistic society, these companies, they manage to patent their waveforms. So they patent the frequency. For example, Nevro has a patent on frequencies from 10,000 to 100,000. So when another company want to do high frequency, they can't go to 10,000. They can do 2,000, 4,000 range. So it's not true high frequency. Like Abbott has a patent on the true physiologic natural neural burst signals that simulates the neuronal burst. When there other companies want to offer burst or say they offer burst, all they can do is have their system turn on and off sequentially without following the real neuronal rhythm. So it's not a true burst. Obviously, the company reps will claim that their device can do everything every other device does, but that's not truly honest. Why I'm telling you this, because this matters, because there's no one program or company that's superior to all others. Like there's no, I mean, in your world, like there's no one plate that's superior to all others, like when you're doing a Hall's valgus correction. Um, so you're gonna customize the implant to your patient pathology and your patient needs. Um, but as you know, in all specialties, there are people who are single company loyalists for whatever deal they have with someone, and their hardware choices are affected by that. So if you're referring your patients to a pain doctor that is a loyalist to a single company and they only use and implant a single type of stimulator, they're probably they're probably harming the patients by limiting their choices. I personally use all the companies. I customize the choice and the device to the patient, and I get them involved in the decision. It's just that's just the right thing to do because there is a reason we have all of these options, and each one of them, what's good for patient A may be bad for patient B, and vice versa. So you gotta be able to offer all of these. Some of the new hardware innovations beyond the first generation of innovations in the 90s that was just better batteries and longer leads and more contacts. Now we have slightly more innovation. We have the what's called closed loop stimulation, DRG stimulation, and wireless stimulation. So closed loop stimulation, all the other devices is just output. There's no input. But except for the Saluda Medical and soon Medtronic, will be the only two devices that can stimulate distally and measure proximally, and it can adjust the stimulation according to the measured response. And they've shown in some trials that they can provide better relief and more sustained relief by having the spinal cord stimulator change its response to the input and it's measuring from the spine. And hopefully, what's uh, could be promising in this, it can lower the chances of stimulation fatigue or tolerance to the stimulation that we see in a lot of patients, unfortunately, with the old generation of stimulators that is, they stop working after a while. Hopefully, with having a closed loop, you can change it around and continue to fool the spine in which you avoid developing that condition. The other advancement is wireless stimulation with companies like Nalu and Stimwave. So most stimulators have a battery, and a battery is implanted. This is the size of a pacemaker battery. Like in this picture, you look in the top left, you have the Boston Scientific battery. So some of the companies offer wireless power source to the simulator. So for example, the Nalu has a tiny implant. It's an RF receiver, and the power source will be worn on the outside. It's like wireless phone charging. StimWave and StimRouter, they have an RF receivers at the tail end of their stimulator. So the power source, again, is an external, not an implantable power source. So this is an important choice for patients with like certain metal allergies, very skinny patients that don't want implantable batteries, Also for peripheral nerve stimulators, where it's not feasible, like to put a battery in someone's flank, trunk area, and tunnel all the way from that to like their posterior tibial nerve. So having wireless power sources is very helpful for those conditions. Now we move on to the real development in neuromodulation, the true paradigm shift, and the leap forward in controlling painful conditions. The Cadillac of stimulation, which is dorsal ganglion stimulation. So I understand of many may be skeptical of regular spinal cord stimulators. I've seen mixed results, failures of them, especially with the older systems. And one of the main issues, as I said, we used to see is stimulation fatigue, in which the patients lose the response over time, whether it's from the nervous system getting used to the signal or whatever other reasons. But DRG seems to have hit the sweet spot for stimulation. Not only the response is much better and more dramatic than regular stimulators, even the new generation stimulators with their fancy programs and bells and whistles, but also since it's working on nerve cell bodies and axons rather than on the spinal cord, sophisticated spinal cord itself that can modulate itself with neuroplasticity. When you're working on the a wire part of the nerve, it's much less likely that you lose response over time. And these patients will continue to have the same response now and 20 years down the line, which is a major advantage. So the DRG is a collection of bipolar cell bodies, neurons surrounded by glial cells, and the axons of the DRG sensory cells are the primary afferent sensory nerves. One of the advantages there's very limited CSF around the DRG. So it allows the leads to be closer to the target. The cerebrospinal fluid works like an insulator, and it prevents the stimulation from hitting its target, or insulates and diminishes the signal from reaching its target. And being at the DRG requires less energy to stimulate compared to conventional stimulators. And the nice thing at the DRG, it's a pure sensory nerves. So since there's separation of sensory motor fibers, there's no unintentional motor stimulation, which is very annoying to the patient, the thumping um, sensation. There are many advantages, mainly is the better pain relief. So in regular stimulators, when we do the trial, we consider 50% pain relief to be success. In lucky cases, which are the norm, we get like 75 percent pain relief. But with DRG stimulation, we get an 80 to 100% pain relief. So our floor is higher than the ceiling of regular stimulators. It's more sustainable long term. As I said, it's less neuroplasticity, and it's a wire rather than a spine that you're trying to um, fool, put it this way. Much less the stimulation in undesired area because you're going right over the nerve root that you want, and a longer battery life because you're stimulating at the nerve root itself. There's no CSF, there's much less energy needed, thus the battery can live longer. So we can use a non-rechargeable battery. So a non-rechargeable battery will easily last more than 10 years in here. Less postural changes, again, with there's no CSF, it's a tight foramen versus wide spinal canal. So when the patient leans forward, backward, lays in bed, they still get the same stimulation, which in regular spinal cord stimulators may not always be the case. So some of the techniques of DRG, those are like the old techniques. So there's the transforaminal technique like StimWave, which is a wireless type of stimulator. It can be helpful in certain cases, but doesn't have a great anchoring system. It's a large diameter lead, can access tight foramens. and you cannot guarantee that it stays dorsal because of you're entering from the foramen from the outside in. Before that, there was before any developments in DRG, some people were trying to use the regular stimulators and come out the foramen. So the old school transgrade way, which is using a regular spinal cord stimulator lead and trying to sneak it through the foramen. So this doesn't steer well, doesn't come out the foramen most of the time. Even it comes out, it's not going to hit the DRG the right way. It doesn't have an anchoring system. It's a large diameter. It's going to cause foraminal narrowing by itself. So not a great solution. Then the truly well-designed DRG stimulator, from top to bottom, this was designed to be a DRG stimulator. So it was originally designed by an Australian company called Spinal Modulation, with the only intent of being a DRG stimulator. Later, it was bought by St. Jude's, who was later bought by Abbott. So this is the only true DRG stimulator that's designed to have good contact with the dorsal ganglion. It has a good anchoring mechanism by these stress relief S loops. The lead size, diameter, material, everything is designed for the foramen. The steering system, the anchoring mechanisms are fully and only designed for this purpose. So there are many clinical trials. One of the first ones was the PROCLAIM trial that compared regular spinal cord stimulation to dorsal ganglion stimulation for the treatment of complex regional pain syndrome. So we've seen 81% pain relief with DRG sustained at 12 months in the DRG population. Compared pain scores post-treatment, it has the highest impact on pain score. It was the only device of anything, of any trial actually in the world of pain for complex regional pain syndrome that was shown to give pain scores on average in the patient population, more than 100 patients, less than 2 out of 10. So if any of you have patients with complex regional pain syndrome, you know how severe the pain is. But to get these patients, most of them are starting at 8 to 10 out of 10. And to get them below 2 out of 10 is very dramatic. So why are we not doing only DRG? That's a question. Obviously, there's many limitations. The main one is the anatomy. If the patient has tight foramens, you can't even do it. But there's many other reasons. So this is Flora. This is one of my patients. It's actually an endometriosis case, not a foot and ankle. It's a bilateral T12L1. So the main thing about DRG, it's very technically challenging. There's probably maybe 5 people in Southeast Michigan trained to do it. The only one who's actively providing it on a larger scale. And many of my colleagues gave up on it because of cost effectiveness. It's the same CPT code as a regular spinal cord stimulator for 10 times the work, sometimes more than 10 times the work. To put it in perspective, like my record for regular spinal cord stimulator trial, not the implant, just the trial, is like 3.5 minutes. But I haven't done a DRG in less than 50 minutes. There's like a difficult revision case, took me 4.5 hours. And it's the same CPT code, so it's, and the code only pays you for the first 2 wires. So everything you do after that is a freebie. And most patients will need more than 2. So like imagine your foot and ankle patient, you're probably gonna have to cover L4, L5, and S1 to cover foot and ankle pain in a lot of patients, unless it's really localized. And imagine like a neuropathy, bilateral peripheral neuropathy, and you're dropping L4, 5, S1 bilateral. So that's 6 wires. You're only paid for the first 2. So, but the outcomes have been so dramatic that it's worth it. It's making it worthwhile for me to continue to do it and offer it. It's like the closest thing to a medical miracle in the field of pain and treating patients with CRPS, like mangled extremities, neuropathies, phantom pain, neuromas, burns, severe deformities. I mean, we had no solution for these patients before this was available. So there's a sucker who needs to offer it, and I happen to be that guy. So, but it's a great treatment. This is an example of a patient treated. He's a 35-year-old gentleman. His work-related injury, his leg was actually degloved in an industrial accident. 35 reconstruction surgeries, severe, obviously, neuroma, CRPS, you name it, from the knee down. Obviously, all kinds of nerve blocks, oral medications. He had a pain pump and a spinal cord stimulator at the same time, and continued to have excruciating pain despite all of that. He had no quality of life. So we did a trial with DRG stimulation. He had more than 80% pain relief. He walked without a cane for the first time in like maybe 15 years. Expanded the pain pump, expanded his ORT simulator, and decreases pain medicine intake by more than 70%. And so basically, DRG stimulation gave him his life back. It's another example. This is actually not my patient, but shared by one of my colleagues. Is someone who had 5 ankle surgeries, ankle replacements, and revision. All had also CRPS type 2. Also happened to have 5 back surgeries at the same time. So ended up being implanted with 4 leads: T12, L4, L5, and S1. So the T12 is for the back pain. So the ones relevant to the foot, L4, L5, and S1, and his foot pain went down from 10 to 0. Numbness improved, color normalized, and no longer taking Percocet. This is not the exception. This is the norm with DRG stimulation. You'll see a lot of that. I welcome your worst patients, your biggest train wrecks, and throw. If they have a Freeman that can take a DRG, you'll see that. You'll see 10 to 0. So now we switch gears and move from the topic of neurostimulation to touch briefly on peripheral nerves, and to talk about their role and treatment options for peripheral nerves in the treatment of pain. So, neurolysis, whether it's surgical, like cordotomy for cancer patients, chemical, phenol, or alcohol ablations, like with celiac plexus ablation for cancer patients, or radiofrequency ablation. So radiofrequency ablation, we know we have the electrode with an exposed tip, and the exposed tip of the electrode, the electric current concentrates around it and creates heat that coagulates the tissue around it. Just anesthetizing the source of pain. So it is coagulating the proteins and denaturing the proteins in the target nerve. It is not cautery. And it depends mostly on the temperature and the size of the exposed tip. So is there a rule for radiofrequency ablation and treating foot and ankle pain? Because continuous thermal ablation is something we offer and perform all the time in the treatment of back conditions, for back arthritis and many other pain conditions. But when it comes to foot and ankle pain, it becomes a lot trickier. First, continuous thermal ablation is only okay for pure sensory nerve. You can't do it for a mixed nerve because you'll cause motor weakness and atrophy. Second, continuous thermal ablation is only okay for smaller nerve branches. Larger, even pure sensory nerve, saphenous, sural. They can develop neuromas. They can develop anesthesia dolorosa. They can potentially be worse off and get neuropathic pain, and they'd be worse off than they went in. So, and then in the foot and ankle anatomy, there's so many peripheral nerves and overlap. There's not great targets a lot of times, especially if the pain, let's say, is arthritic uh, versus neuropathic. So one of the solutions would be a pulse RFA, in which the temperature doesn't go up to like 80, 90 degrees like we do with continuous ablation. It goes up to 42 degrees, and it goes in pulses of heat with intervals of quiet in between. As you see in the figure, will be like a 2 hertz a second. Some of the nerves that may be targets for thermal ablation, continuous thermal ablation in the foot, are probably Morton neuroma or Baxter's nerve. Otherwise, pulse RFA is your way to go. So since we can't ablate or denervate most lower extremity nerves, peripheral nerve stimulation can be a reasonable option for some patients. So this is a list of FDA-approved peripheral nerve stimulations for in the entire body. Actually, even now, the head and neck, they have some FDA-approved nerves in that. But what's relevant here is in the lower extremity. So these are some of the commonly stimulated nerves. More commonly, none of them is commonly stimulated, but some of the more commonly stimulated. So the saphenous nerve, post-surgical trauma, compression, viral infections, tibial nerve, tarsal tunnel, or even post-tarsal tunnel surgery if they still have pain or they develop neuroma or develop any type of neuritis post-operatively, crush injuries and trauma. A common fibular nerve, trauma compressions, and athletic injuries. Sural nerve, again, for, trauma, Jones fractures, traction entrapments, and myalgia paresthetica lateral femorocutaneous nerve is probably a little bit more proximal to the foot and ankle territory. So the sural nerve, we catch it posterior to the lateral malleolus. It can be done under ultrasound. So, and with like regular stimulators, the patient gets to do a trial before they do the final implant, and they only go through if they have a significant relief in the trial. So they wear a temporary wire for about 5 to 7 days, and if only if they like it, they can go ahead and get a permanent one. Fibular, catch it distal to the fibular neck as it curves. You can see on ultrasound the fibular head and neck. Then the tibial, you catch it just medial malleolus. If you have, again, the tarsal tunnels, if they still have pain post-operatively for whatever reason, you can consider that. Look at ultrasound, you're Tom, Dick, and very nervous Harry. In saphenous, you usually catch it proximal to the knee. Yeah, one of the main rules, you don't cross a joint with those peripheral wires, otherwise it will migrate, it will never stay in place. So this is basically an adductor canal. So until recently, we only had permanent peripheral nerve stimulators. Where there were 3 companies, TimWaves, Timrata, and Nalu. Now we have an option for temporary peripheral nerve stimulators, something called Sprint PNS. I don't know if any of you have heard of it. It's funded by the Department of Defense mainly. And they have multiple very reasonable randomized controlled trials, showed good results and sustained pain relief. And the nice thing, they showed that with putting a temporary stimulator for 30, 60 days, they showed sustained pain relief up to 12 months from the implant. So this could be a good option for patients with subacute post-operative pain, major surgeries, major trauma, asphyxiation. Think of it as like a 60-day nerve block. You know, obviously you can't block a nerve for that long because you get local anesthetic toxicity to the nerve from the local anesthetic, and and you get muscle atrophy from motor blockade. But if you can stimulate the nerve instead of blocking it, you get the good effects of a nerve block without the side effects of a nerve block. You don't get a motor blockade, you just get the decrease in the perception of pain. So it's basically a teeny flimsy wire is temporarily placed. It's the least invasive peripheral nerve stimulator option. If you look at it here, it's so tiny. Uh, it's a short-term implant, and a lot of these patients with, let's say, subacute pain that will hopefully resolve and go away. You can think of this as an option. As a matter of fact, there are few surgeons that will preemptively implant this during the operation, knowing that the patient is going to have severe pain post-operatively. So that's not even something you need me for, but something you can consider too in your practice. So in summary, neuromodulation, we have lots of advances, exciting advances. It's safe and effective treating post-operative neuropathic and various causes of foot and ankle pain. We have a lot of advances in software and hardware. And just to add one last thing, these systems aren't mutually exclusive. You can have a hybrid of more than one system in one patient. I have a handful of complete train wreck patients that have a combination of spinal cord stimulator, DRG, and even PNS. And even a couple of them have a pump for baclofen for spasticity. So there are some times where you have to mix those systems and try to give them the best of each world. So thank you very much for listening, and enjoy the rest of your conference.